Thank you, Dr. Mitunga, for the introduction, and thank you to the organizers. I have no disclosures. So this is the outline of my presentation. We'll talk about acute and chronic pancreatitis. First, focusing on acute pancreatitis. And so acute pancreatitis is a very common diagnosis. It's the leading cause of GI admission in the US, and it accounts for more than 275,000 patients hospitalized annually. Accounts for an aggregated cost of over $2.6 billion per year. And it is associated with a recurrence in up to 22% of patients. And overall, the mortality is about 2%, but it may be up to 17% in severe acute pancreatitis. To make the diagnosis, you need to have two of the following three criteria: presence of typical abdominal pain, a serum amylase or lipase that's greater than 3 times the upper limit of normal, or characteristic findings on abdominal imaging. So if you have the first two, you do not need to do abdominal imaging. So what is typical abdominal pain? So usually it's epigastric pain or left upper quadrant pain that can be diffuse. It can be constant and radiate to the back, the chest, or the flank, and the pain is usually severe. What is not considered consistent is if it's a dull, colicky pain or located in the lower quadrant. Then you should think of something else. So hyperlipidemia is not enough to say the diagnosis of acute pancreatitis. In this cohort, we looked at all patients with lipase greater than 3 times the upper limit of normal in our institution. So we looked at 600 patients, and of those, only 52% had acute pancreatitis. So lipase alone is not enough. And so really, abdominal imaging should only be done if you do not meet the two first criteria. And so it is not recommended initially, except if the diagnosis is unclear or if the patient failed to improve within 48 to 72 hours. And this is then to assess for local complication. So you will want to wait at least 2 to 3 days before doing imaging to look for local complications such as necrosis. And this is a graph that shows that despite this recommendation, the use of imaging such as CT and MRI in the emergency room is significant and actually rising. So we really need to do a good job about not doing imaging when it's not necessary initially. So once you've made your diagnosis, then you have to think of the etiology. Common cause such as gallstone and alcohol are the two main causes of pancreatitis. And another one, the third leading cause, is hypertriglyceridemia, which accounts for about 5% of the cases. And then less common cases are listed here. So what should be your initial workup? You should look at a triglyceride level, and ideally this is done in the emergency room because this is when you'll be able to pick up a high triglyceride that can cause pancreatitis. Usually it needs to be above 1,000, but actually any triglyceride elevation can have an influence on the course of the disease for even other etiology of pancreatitis. So triglyceride level early on is very important. The other important initial workup is abdominal ultrasound, and this should be performed in all patients to assess for presence of gallstone pancreatitis, as we said is the leading cause of pancreatitis. So once we've thought of the etiology, we need to look into severity classification. So we use the revised Atlanta classification that classifies cases as mild, moderately severe, or severe pancreatitis. Mild pancreatitis is defined as the absence of organ failure. Moderately severe is defined as a local or systemic complication without persistent organ failure or transient organ failure. And severe pancreatitis is defined as persistent organ failure lasting more than 48 hours, which can be further stratified as single or multisystemic. And the patients with the worst outcome are the multi-system persistent organ failure. And organ failure is classified using the modified Marshall score. So this is a picture of necrotizing pancreatitis. You can see that there's loss of enhancement of the pancreas. This is an acute peripancreatic fluid collection. and this is acute necrotic collection. You can see that the necrotic collection is heterogeneous when you compare it to the acute peripancreatic fluid collection of the previous slide. So there's a lot of different prognostic factors that can be used. There's some clinical parameters, including older age, obesity, alcohol intake, and hypertriglyceridemia-induced pancreatitis, which usually are associated with worse outcome. And there's also laboratory or imaging findings, such as presence of hemoconcentration, elevated CRP, that's usually reliable after 48 hours, elevated BUN, creatinine, presence of pleural effusion, or abnormal CT scan, as I've showed previously. There's also a lot of scoring systems out there, including the harmless acute pancreatitis score, which is a score that helps you see who will have a milder course and could potentially be discharged earlier on, SIRS criteria, and BISAP score that has been developed at the Brigham that is associated with worse outcome and higher mortality. More criteria are found. In terms of initial management, there is no approved treatment for acute pancreatitis. And so the main treatment is supportive. We do recommend goal-directed therapy using isotonic crystallate solution and would generally favor lactated ringer or NS, but lactated ringer was a small randomized trial that was done at the Brigham that showed improvement in the inflammatory parameters. And so based on this, we tend to use lactated ringer. We usually give 5 to 10 milliliter per kilogram per hour, with some exceptions if they cannot tolerate aggressive replacement. And it's important to note that aggressive IV hydration is really the most beneficial in the first 12 to 24 hours. So really early on, when the patient presents in the emergency room and you find a diagnosis of acute pancreatitis, this is when you need to start those IV fluids. Beyond that, they may be of little benefit, but it's important to follow the markers, follow the urine output, and continue goal-directed therapy as needed. Pain management is also very important in acute pancreatitis because pancreatitis is extremely painful. Opioids appear to be safe and effective. And we've actually looked at that and we found that neither the prescription of opioid at discharge nor the prescribed dose was associated with early readmission. In another study, we found that about half of the patients admitted with acute pancreatitis were discharged with a new opioid prescription, and a lot of them actually had a very low pain score of 3 or less. So we have to understand better what is the role of opioids and when it's appropriate or not to be prescribed, especially in this current opioid epidemic. Another important management is nutrition. So the American Gastroenterology Association recommends early oral feeding, which usually is defined as within 24 hours. And this is for pancreatitis regardless of the severity. There was an important clinical trial that was published in the New England Journal in 2014 that showed that oral feeding was tolerated compared to enteral feeding and was associated with better outcomes than enteral nutrition, which I was surprised to find. But based on this, everyone should start oral feeding if they tolerate it. Under what form? So a low-fat diet appears to be as safe as clear liquid diet. And then only if oral intake is not tolerated that you should use adjunctive therapy. And ideally, you use your enteral nutrition support over parenteral. And so really you should use parenteral nutrition only if the patient does not tolerate oral or parenteral or enteral support. And nasogastric and nasojejunal feeding appeared comparable in efficacy and safety, but there's more studies that need to be done about this. So what is the role of antibiotics? It should be given to any extrapancreatic infection such as cholangitis, and the routine use of prophylactic antibiotics in patients with predicted severe acute pancreatitis is not recommended. So this is important. Now, how about ERCP? So patients that have acute pancreatitis and cholangitis should undergo ERCP within 24 hours of admission. And an important note is that there is no need for ERCP in most patients with gallstone pancreatitis without laboratory or clinical evidence of ongoing biliary obstruction. So this is important. So not all patients that have biliary pancreatitis will need an ERCP. So how about management of complications? So first, infected necrosis. As you can see here, you have your necrosis with a lot of air bubbles. So this is very suggestive of infected necrosis. So you first should suspect infected necrosis if a patient has necrosis and he deteriorates or fails to improve after 7 to 10 days. So we usually think of infected necrosis earlier on, but it usually takes at least 7 to 10 days to become infected. And once you have this suspicion, if you can, a CT fine needle aspiration should be done prior to the antibiotic, if possible, to sample and send culture and sensitivity to make sure your antibiotic is going to be appropriate coverage. In terms of antibiotic, you can use carbapenem, quinolone, and metronidazole, which are antibiotics that penetrates the pancreatic necrosis or penetrate the pancreas, and they may be useful in delaying or even avoiding intervention. So antibiotics is very important. And of note, the routine administration of antifungal is not recommended. And there was a randomized trial of a single center that compared minimally invasive surgery versus the endoscopic step-up approach. And they looked at composite endpoint of major complication. And what they found was that there was 40.6% of the minimally invasive group versus 11.8% of the endoscopic group that met this composite endpoint of major complication. And so there were more major complication and a higher cost in the minimally invasive surgery group. So based on this, really the advantage has gone towards proceeding with endoscopic step-up approach. And you see here an endoscopic necrosectomy being performed. For note, there was no difference in mortality in this study. So other local complications such as pseudocyst, as you can see here. So there's a wall and the fluid is homogeneous, and here walled-off necrosis where there is a wall and you can see that the inside is heterogeneous. This is walled-off necrosis. So if the patient is asymptomatic, it does not warrant any intervention regardless of the size, location, and extension. So prevention of recurrence, just want to briefly touch on this. So for gallstone pancreatitis, in mild acute pancreatitis, cholecystectomy should be performed before discharge. And in necrotizing gallstone pancreatitis, cholecystectomy should be deferred until active inflammation subsides and the fluid collection resolve or stabilize. So it's okay to wait. I know a lot of patients are nervous, but it's definitely okay to wait. Another important prevention is in acute alcoholic pancreatitis. So the American Gastroenterology Association recommends a brief alcohol intervention during admission. This is based on a randomized control trial that compared repeated 6 months interval intervention for 2 years, so 4 interventions versus a single intervention during admission. And they found that both were similar and with no statistical significant difference, but there was a trend toward reduction in hospitalization in the single intervention group. So based on this, it's really important to take the time and counsel against alcohol in those patients. So now if we segue and talk a little bit about chronic pancreatitis. So the definition is reversible damage to the pancreas and development of histologic evidence of inflammation and fibrosis with eventual loss of exocrine and endocrine tissue. It's associated with a prevalence of about 50 per 100,000 patients in the US, and it's more common in men than women. The median age of diagnosis is between 30 and 40 years old, and it is associated with a 10-year survival of only 70%. So those patients do die earlier than their general population. The clinical presentation is very varied. They can present with recurrent pancreatitis, nausea, vomiting. They can have abdominal or back pain, some weight loss. They can have frequent stool. They can also have gas, a small smelling oily stool that I've depicted here, steatorrhea. They can also have bloating and cramping. So a lot of patients can present with kind of IBS symptoms. So you have to have a high index of suspicion. The pain pattern is very variable. So there's 16% that have no pain, and it can go all the way up to severe constant pain. And so there's no typical pain presentation in those patients. In terms of laboratory finding, you can have a low albumin and prealbumin, a low liposoluble vitamins, A, D, E, and K. They can also have low vitamin B12, low lipase, especially if they have a lot of acinar cell loss. They can also have a low fecal elastase, which is a stool test that measures indirectly the exocrine pancreatic function. Of note, this is a stool test that needs to be done on a form stool. If the stool is liquid, you will have a false positive test. And a fecal elastase of over 200 is normal. Below 100 is definitely abnormal. So this is an important tool in your patients with chronic pancreatitis. The imaging is also important, and there's a step-up approach. So step one, you want to do a CT scan, and you want to look for presence of calcification, pancreatic atrophy, see if you can see pancreatic duct dilation. Of note, though, calcification and atrophy are not pathognomonic of chronic pancreatitis. So there's a lot of other things that can cause calcification. Those other cases, the calcification are usually focal. Atrophy, the most common reason for atrophy is actually aging. So atrophy alone is probably not enough to make the diagnosis of chronic pancreatitis. Step two of imaging, if you do not meet criteria based on your CT scan and you have a high index of suspicion of chronic pancreatitis, you should now proceed with MRI, MR pancreatography. This will help you highlight the pancreatic duct, the dilated pancreatic side branches, the irregularity of the main pancreatic duct, and you can also see a T1 change of the signal of the pancreas that shows some sign of fibrosis. If you do not have enough diagnostic criteria with the step two, the next step is to perform an endoscopic ultrasound, and the endoscopist will identify presence of 9 different criteria, 4 that are parenchymal and 5 that are ductal. And if you have at least 5 of those findings, you have a diagnosis of chronic pancreatitis. Again, you have to be careful because some patients can have findings such as hyperechoic foci, hyperechoic stranding that are depicted up there. And those are, if you just have a few, 2 or 1 or 2 or 3, that's probably not enough to say chronic pancreatitis. So you have to be careful of not overdiagnosing chronic pancreatitis. So once you've made your diagnosis, the next step is to think of the etiology. So chronic pancreatitis is not just alcohol. There's the Tiger-O classification that helps you think of all the different causes. In the toxic metabolic classification, alcohol and smoking are high up there. As we know, they are toxic to the pancreas and they amplify each other when they're combined. Another etiology that I want to highlight is genetic. So PRSS1 mutation is a mutation associated with hereditary pancreatitis. It's an autosomal dominant mutation. And this is something that we see with family, multiple family members, an increased risk of having acute and chronic pancreatitis. And it is associated with a 40% risk of pancreatic cancer at 70 years old. So it's very important to make that diagnosis if this is what you have, because you're going to have to be very vigilant on those patients. There's other mutations that are listed here, SPINK1, CFTR, and cystic fibrosis, CTRC, to name a few. Autoimmune pancreatitis, recurrent, and then obstructive. And think of obstructive because pancreatic cancer can also present as chronic pancreatitis. So you have to be careful. So I just want to talk a little bit about autoimmune pancreatitis. This is defined as diffuse enlarged pancreas with featureless borders, which can often be described as sausage shape with delayed enhancement and a capsule-like rim. In type 1, you have an elevated IgG4, and it's associated with the IgG4 related disease. And the reason I mention this is that it does respond to steroid. And so if you have this diagnosis, you're able to treat it, you may preserve exocrine and endocrine function of your pancreas. So it's good to think of that because if you catch it early, you can have a significant impact on the natural history. So once you've looked at your etiology, you have to look for complication. Type 3C diabetes, exocrine pancreatic insufficiency are two things we think of in chronic pancreatitis, but you have to remember that a lot of patients with chronic pancreatitis have metabolic bone disease and are prone to low trauma fractures. So this is something we need to think of. And then pancreatic cancer, of course, the overall lifetime risk is about 4%, but it does increase if the patient smokes, if they have coexisting diabetes, and in hereditary pancreatitis. There's also other complications that are much rarer, including splenic vein thrombosis that can present with gastric variceal bleed that you should usually treat with a splenectomy, pseudocysts that we see actually much more frequently in acute pancreatitis, and then bile duct obstruction from inflammation and duodenal obstruction. So therapy. So the most important thing to do when you have those patients with chronic pancreatitis is really to provide extensive counseling on smoking and alcohol cessation, because that really can impact course of disease, pain, risk of cancer. So it's really important. It's also very important to do proper nutritional counseling and check for calcium and vitamin D and provide supplementation if needed. And then also check the bone density to make sure they do not have osteoporosis. In terms of analgesia, we usually recommend to start low and slowly increase. So Tylenol, NSAID, Tramadol. You can give adjunctive therapy for those with worsening pain, and you slowly increase as required. And of course, pregabalin has been proven in a randomized trial to be effective in pain control in chronic pancreatitis. And you also, of course, want to make sure you assess your exocrine and endocrine function regularly. A note on pancreatic enzyme replacement. So the normal pancreas produces 900,000 units of lipase per meal, and you need about 10% of that for normal digestion. So I usually start with 50 to 75,000 units of lipase per meal and 20 to 35,000 units of lipase per snack. Often patients that are referred to me are not on adequate treatment. And it's important to give it at the right time because it's temperature sensitive, and it also has limited time of effect. So you want to take the first pill at the beginning of the meal and then the second pill halfway through the meal. Taking the pills at the time of the meal is when it's going to be the most effective, versus before and after is the least effective. And so endoscopic and surgical treatment are the next step if your conservative management has not been effective. And you will think of those different ways of treating according to the anatomy. So if you have an inflammatory mass in the head of the pancreas, you can think of surgeries such as the Whipple operation that is depicted up here, where the head of the pancreas is removed, as well as the duodenum and sometimes part of the stomach, as well as the gallbladder. If you have a dilated pancreatic duct, you can consider endoscopic therapy, where you will perform potentially a pancreatic sphincterotomy, stricture dilation and stenting, potentially lithotripsy and stone extraction, or surgical therapy, which is often the modified Pusteaux that's depicted here, where the pancreas duct is sliced open and is connected with the jejunum, as you can see here. And then for small duct disease, you will think of surgical options such as the V-plasty or total pancreatectomy with islet cell autotransplantation, which is major surgery that is offered in centers of excellence for pancreatic care. So take-home message. So acute pancreatitis, remember you need to have 2 of the following 3 criteria for diagnosis. Remember to check an ultrasound to assess for presence of gallstone, and also do your triglyceride level in the emergency room to have an accurate measurement. And you really want to wait after the initial 48 to 72 hours to obtain a CT scan. And you want to favor the enteral route whenever you can. Chronic pancreatitis, think of the etiology other than alcohol. Autoimmune pancreatitis can be treated with steroids, so really this is an important one to make. And remember to the diagnosis and treatment approach according to the anatomy, and do monitor for complication and treat accordingly. So questions. So question number 1, what is the optimal timing of cholecystectomy in patients with mild biliary acute pancreatitis? A, 1 week after the episode. B, 1 month after the episode. C, during the admission. And D, 6 months after the episode. So we have almost 230 patients the people that answered C during the admission. That is correct, during the admission, and this is the reference. Decreases readmission for recurrent gallstone pancreatitis. Thank you. Question 2. What gene is most associated with hereditary pancreatitis, and what genetic inheritance pattern does it follow? And it's depicted below. So A, PRSS1, autosomal dominant with incomplete penetrance. B, CTRC, autosomal recessive. C, CFTR, mitochondrial inheritance, and then D, SPINK1, X-linked recessive. Cue music. Oh, it's coming. All right, so most people answered 1A, PRSS1, autosomal dominant. That is the correct answer. All right, thank you so much for your attention. Here are some references. Thank you for your time.
Thank you. So thank you, Julia, for excellent review of acute and chronic pancreatitis. Have a couple of audience questions that hoping we could go over. So one question was, is one pancreatic enzyme supplement superior to another in patients, say, with chronic pancreatitis?
Oh, that's a good question. So most pancreatic enzyme are encapsulated. So creon, the creon pancrease, they're all, except for viocase, they're all encapsulated. So that means that when you take those enzymes, they have a capsule that is protecting the enzyme from the acid in the stomach. And so you do not need to take anything else on top of that. And it does not usually cause ulcers in the mouth. Those are usually the ones that are most readily available in most pharmacies. And then there's a distinction with an enzyme that's called viocase that is not encapsulated. So that one is in theory helpful in pain because in theory it will decrease stimulation of the pancreas, but this has not been proven efficacious. And so when you give this viocase, you need to give it with acid suppressive therapy to make sure that the stomach acid does not inactivate it. So that's the main distinction. There's also some that contain bicarbonate that are new on the market, but in general, they're all similar equivalent. It's really the amount that you give. So you have to make sure you're giving at least 50 to 75,000 units of lipase per meal. So this is much higher than most people usually prescribe. So you have to be careful about that.
Great. And one last question, hopefully a quick one. It says that in acute pancreatitis, when would you consider checking like the IgG subtypes? Is that something that you do early on, or is there scenarios that you might?
So it's a good question because autoimmune pancreatitis type 1, which is associated with IgG4 elevation, it does not usually present with acute pancreatitis. It tends to present more with painless jaundice and inflammatory mass in the head of the pancreas. And so we often kind of get tricked. The type of autoimmune pancreatitis that do present as acute pancreatitis is type 2 autoimmune pancreatitis that is not associated with a rise in IgG4. So I still usually check the IgG4 to be careful, but in general, autoimmune pancreatitis type 1 with high IgG4 is not a presentation of acute pancreatitis. So I usually check it like initially, or if I see them in follow-up after discharge once. But it's not a very high yield test. More important is to check the triglyceride in the emergency room.
Great. Thank you so very much. Great lecture.